Examining the cervical spine. Begin inspection immediately upon meeting the patient. Does the patient's head move naturally with his body movements? The anterior and posterior neck should then be inspected for any abnormalities such as asymmetry, blisters, scars, and discoloration. Find the following landmarks. On palpation of the anterior neck, the hyoid bone is at level C3. To find it, have your patient move his tongue far back in his mouth. The hyoid bone becomes prominent. The thyroid cartilage is at level C4, C5. It's also known as the Adam's apple. The cricoid ring is at level C6. Palpate the sternocleidomastoid muscles for tenderness, masses, muscle spasm, or tissue texture changes. On posterior palpation, find the occiput, the mastoid processes just behind the ears, and the spinous processes of the cervical vertebrae. Palpate the trapezius muscles for tenderness, masses, muscle spasm, or tissue texture changes. Next, we perform range of motion. Determine both active and passive range of motion. Active range of motion is when the patient performs the movements without your assistance. Flexion, extension, side bending, rotation. Passive range of motion is moving the patient without their assistance. Flexion, extension, side bending, rotation. Last is muscle strength. Remember to grade the strength correctly on a scale of 0 to 5 out of 5. For sternocleidomastoid strength, have the patient rotate his head against resistance. For trapezius, have the patient shrug his shoulders against resistance. For neck flexors, have the patient try to bring his chin to his chest with your hand on his forehead. For extensors, have the patient try to turn his head to the ceiling with your hand on the back of his head. Examining the thoracic and lumbar spine. Expose as much of the patient's trunk as possible for inspection. Observe your patient's posture while walking, standing, and sitting. Are the muscles of the back symmetrical? Is there obvious hypertrophy or atrophy? Do you see lordosis or kyphosis? Find the following landmarks through palpation and make note of any abnormality. Spinous processes. Sacral base. The paraspinal muscles, and the supraspinatus ligament, which may be palpated over the lumbar vertebrae. Perform range of motion, either active, passive, or both. We'll perform active range of motion in this example. Flexion, extension, lateral bending, rotation, and lastly, have the patient stand and bend forward from the hips, inspecting for scoliosis. The upper extremity exam. The upper extremity exam includes the shoulder, elbow, wrist, and hands. Expose the areas for inspection. Inspect both the upper limbs, including the clavicles and scapula, for symmetry, presence or absence of joint edema, color changes, or deformity. The shoulder includes the glenohumeral and acromioclavicular joints. Palpate the following landmarks: suprasternal notch, sternoclavicular joint, clavicle, coracoid process. This one can be a challenge. Put your hand on the deltoid muscle and drop a finger or a thumb just below the clavicle. Acromioclavicular articulation. Run a finger along the clavicle until you reach the joint. The acromion and the greater tuberosity of the humerus. Bicipital groove. Follow the biceps tendon up until you feel the indentation on the humerus. And palpate the spine of the scapula at the level of T3. Note the vertebral border of the scapula. Soft tissue palpation of the shoulder. 3 of the 4 rotator cuff muscles can be palpated. The supraspinous occupies the supraspinatus fossa of the scapula. The infraspinatus is found below the spine of the scapula and is partly covered by the deltoid and trapezius. The teres minor is a narrow muscle inferior to the infraspinatus and is completely hidden by the deltoid. The subscapularis forms the posterior wall of the axilla. Palpate the remaining prominent muscles of the shoulder girdle, the deltoid, biceps, triceps. Note any tenderness, tissue texture changes, etc. Perform range of motion. Make sure to complete the full motion to end point to accurately assess for asymmetry or restriction. Always compare joints bilaterally. We'll perform passive range of motion for this example. When examining the shoulder, flex the elbow to make sure the shoulder movements are easier to visualize. Abduction, adduction, flexion, extension, internal rotation, external rotation. To test muscle strength of the shoulder, abduction, have the patients push their arms laterally. Adduction, have the patient push their arms medially. Flexion, have the patient push their arms against you. Extension, have the patient push their arms backward. Internal rotation, with the elbow flexed and the upper arm at the side, have the patient turn his forearm toward his abdomen against resistance. External rotation, with the elbow flexed and the upper arm at the side, have the patient turn his forearm outward against resistance. Remember to grade the strength on a scale of 0 to 5 out of 5. Examining the elbow. In addition to your general inspection, make note of your patient's carrying angle and look for any swelling of the olecranon bursa or nodules. Palpate the following landmarks on both elbows. Medial epicondyle of the humerus. Olecranon. The ulnar groove between the medial epicondyle and olecranon. Lateral epicondyle of the humerus. And the radial head. You can feel this move when the forearm is rotated. Perform range of motion, either active, passive, or both. Compare bilaterally. Flexion, extension, supination, palm up, pronation, palm down. Perform muscle strength. Don't forget to grade the movements. Have the patient flex while the examiner opposes the motion. Have the patient extend while the examiner opposes the motion. Have the patient supinate while the examiner opposes the motion. Have the patient pronate while the examiner opposes the motion. Examining the wrists and hands. Inspect both hands for any masses, lesions, nodules, discolorations, position shape, and completeness of the digits. Remember to inspect both the palmar and dorsal surfaces of the hand. Inspect the fingernails for abnormalities. Palpate the following landmarks. Radial styloid, ulnar styloid, anatomic snuff box. This is bound by the thumb extensors. Tenderness in the anatomic snuff box is suggestive of a scaphoid fracture. Palpate the remaining carpal bones. Palpate the metacarpals, the metacarpophalangeal joints, proximal interphalangeal joints, distal interphalangeal joints. Perform range of motion, active, passive, or both. Flexion, extension, ulnar deviation, radial deviation. For the fingers, flexion, extension, ulnar deviation, and radial deviation. For the thumb, flexion, extension, and opposition. Have the patient touch the tip of his thumb to each of the other fingers. Perform muscle strength and grade on a scale of 0 to 5 out of 5. Test grip strength. Wrist flexion, wrist extension, wrist ulnar deviation, and radial deviation. The hip examination. For inspection, examine the hips while the patient is walking, standing, and lying down. For a routine exam, we do not often expose the hip joint. However, if your patient has a complaint specific to the hip, you must directly visualize the area. Palpate the following landmarks. On anterior palpation, the iliac crest, the anterior superior iliac spine. On posterior palpation, the posterior superior iliac spine, also referred to as dimples of Venus. The greater trochanter of the femur, the sacroiliac joint, S2 is the midpoint of the SI joint, and the piriformis muscle, halfway between the greater trochanter and the middle of the sacrum. Perform hip range of motion and compare bilaterally. This can be done as active range of motion standing if your patient is steady. Ideally, it is done lying down. Flexion, knee extended. Flexion, knee flexed. Extension can be performed with your patient on the edge of the exam table, on his side, or prone. Abduction, adduction, an internal rotation of the hip, best visualized with the knee flexed. An external rotation. Perform hip muscle strength, compare bilaterally, and grade appropriately. Flexion, have your patient push up against resistance. Extension, have your patient push back against resistance. Abduction, have your patient push his thighs apart. And adduction, have your patient push his thighs together. To test internal rotation, externally rotate your patient's hip and have him try to bring it back to midline against resistance. To test external rotation, internally rotate your patient's hip and have him try to bring it back to midline against resistance. The knee examination. Inspection of the knee. Observe the lower leg alignment with patient standing. Look for deformities, swelling, masses, or color change. Palpate the following landmarks bilaterally. Medial and lateral femoral condyles. Patella and infrapatellar tendon. The tibial tubercle. Medial and lateral tibial condyles. Head of the fibula. Fibular head is situated at about the same level as the tibial tubercle. Palpate the popliteal fossa for the popliteal artery and any abnormal masses. Perform range of motion, making sure to take the joint through a full motion. Flexion, extension, internal and external rotation are best performed by the examiner. Perform muscle strength testing. Knee flexion, knee extension, internal rotation. Externally rotate the knee and have the patient try to return his knee to midline against resistance. External rotation. Internally rotate the knee and have the patient try to return his knee to midline against resistance. Examining the ankle and foot. Inspect your patient's ankles and feet, standing, walking, and sitting. Note any swelling, deformities, number and position of toes, straightness, flatness, proportion of toes when compared to the other foot. Palpate landmarks of the ankle and foot. Medial malleolus. Lateral malleolus. The large bones of the ankle. The fifth metatarsal head. The dorsalis pedis artery located over the medial aspect of the dorsum of the foot. And the posterior tibial artery located posterior and inferior to medial malleolus. Insertion of the Achilles tendon combined with tendon of the gastrocnemius and the soleus muscles. Perform range of motion. Ankle dorsiflexion, ankle plantar flexion, subtalar inversion, subtalar eversion, forefoot abduction, forefoot adduction. Perform muscle strength and grade appropriately. Ankle dorsiflexion, ankle plantar flexion, inversion. Place the ankle in eversion and have the patient return to neutral. Eversion. Place the ankle in inversion and have the patient return to neutral. Flexion of the toes, extension of the toes. The Apley Scratch Test. This is the quickest active way to evaluate a patient's upper extremity range of motion. First, to test abduction and external rotation, ask the patient to reach behind his head and touch the superior medial angle of the opposite scapula. Then, to test internal rotation and adduction, have the patient reach behind his back to touch the inferior angle of the opposite scapula. This is a good screening test for adhesive capsulitis, also known as frozen shoulder.